My name's Adam Brufsky. I'm a professor at the University of Pittsburgh. I'm co-director of the Cancer Therapeutics Program at the UBMC Hillman Cancer Center there in Pittsburgh, or Comprehensive Cancer Center. And I've been working for a while with real-world evidence, in particular, a lot of the real-world evidence around CDK4/6 inhibitor use. And we have a lot of really interesting data, that we can talk about in this and kind of help the practicing oncologist kind of understand and make sense of a lot of what's out there. So, with that, I'll give you a case. So we start with a case. This is a 51-year-old woman. She has low back pain for 6 months. You examine her. She's got a 4-centimeter left breast mass. And she has a past medical history significant for right bundle branch block on her EKG. You biopsy her mass. It's an adenocarcinoma consistent with breast. The ER is 90% of the PR is 50%, the HER2 is 1+. You stage her because she has back pain. And she has lytic bone lesions in the lumbar spine, left iliac crest, and a 3-centimeter liver lesion. And so really the question is, what do you do? This is kind of the real question that a lot of us have had for many, many years, at least going back a decade, if not longer. And I think the field has really changed somewhat dramatically since I've been doing it. So, just to kind of give you this is from a long time ago, a review that Maura Dickler and I wrote for The Oncologist. And there's a lot of ways we've exploited the ER pathway in metastatic breast cancer. And you can see here, we have, the aromatase inhibitors, obviously, that are very, very old. They're almost 25 years old in terms of their clinical use in breast cancer. They block the conversion of peripheral steroids to estrogen. We also have, they could be steroidal or non-steroidal, and there's some kind of non-cross resistance between the two. But the bottom line is that estrogen also gets into the cell, and it can be blocked in its interaction with the estrogen receptor by SERMs, such as tamoxifen and toremifene. We also have new ones, lasosoxifene, actually, very interesting drug. It was initially abandoned, it's been repurposed for actually people who have progressed on a CDK4/6 inhibitor. We have a lot of oral degraders. We have fulvestrant, which is an IM degrader we've had forever. It's generic now. But we have lots of oral SERDs, and we're hearing a lot about oral SERDs, a very important trial at this ASCO in a few months about camizestrant. We already have data from elacestrant and imlunestrant. We'll have more. But then there are all these bypass pathways of the PI3 kinase mTOR AKT pathway, and we have lots of things. Capivasertib, alpelisib, and a lot of other ones. So that's a really active area, actually. There's intravenous, gelatolisib. There's a lot of different AKT and PI3 kinase inhibitors. And there's combo mTOR inhibitors. We had everolimus forever, but we now have combo PI3 kinase mTOR inhibitors right out there. But the bottom line is they all converge on cyclin. And so, again, you have cyclin, you have CDK4/6, and CDK4/6 phosphorylates retinoblastoma protein, which pops off of V2F, and then allows the cell cycle to go on. So if you inhibit CDK4/6 with a CDK4/6 inhibitor, I think everybody knows what tends to happen is that the cells stop proliferating because you can't get E2F. And that's the whole idea behind these. These are cytostatic drugs, they're not cytotoxic drugs. So that's important to know. So anyway, with that, we've had 3 major CDK4/6 inhibitors that have been developed. So there's palbociclib, ribociclib, and abemaciclib. And palbociclib and ribociclib generally chemically look fairly similar, and they're fairly similar in their kind of at least neutropenic toxicity profile. Abemaciclib is a little bit different. It binds a little bit more tighter to CDK4 than CDK6 than the other two. And so there's a lot less neutropenia, but because it actually interacts with other CDKs like CDK9, you get a unique toxicity profile, diarrhea in particular. But the most striking thing that we've realized in 10 years of doing this and looking at all the randomized trials, and I'll just talk about the first line, we're not going to talk about the second line, but really in the first line is that the progression-free survival hazard ratio is the same, regardless of the CDK4/6 inhibitor and regardless of the partner, to be honest with you. That hazard ratio, as you can see here, for progression-free survival is 0.56, 0.57, 0.55. They're pretty much the same. That's striking. There are small differences in the absolute benefit from these. Generally, you consider about a doubling of benefit, but that kind of is more associated with the patient populations that are being treated. They're not exactly identical across all of the CDK4/6 trials, specifically in the first line. But I think what has come out, specifically actually probably since the 2022 ASCO, is that there are at least apparent survival differences between the CDK4/6 inhibitors. Now, I say apparent because the patient populations are completely different, really, between them. Palbociclib, and I'm going to go into this in a little bit of detail in a minute, the patient population with palbociclib is clearly different than the ones that were from ribociclib and abemaciclib. And we'll talk about that in a minute. And the other thing is that overall survival was a secondary endpoint in all these trials. And as a result, the trials were not powered for overall survival. So the fact that one happened to have enough power for overall survival and the other two didn't, is something to think about when you say, well, one may have overall survival benefit, the other two don't. So that's kind of important to kind of talk about as we get a little bit further into this. And again, the overall survival benefit, this is data from Paloma 2 that I'll just focus on briefly. But in Paloma 2, generally, it was designed before we understood that you couldn't go from letrozole to letrozole and palbociclib. And this trial, actually, that's what it did. It actually took people who were on letrozole and had progressive disease within 12 months of being on their letrozole, about a quarter of the patients, and actually randomized them to letrozole placebo or letrozole palbociclib. So, the bottom line is that these are patients who were already on letrozole and were randomized to letrozole, or were on letrozole and just got palbociclib with letrozole. So, we know now that those patients probably need to be on some sort of SERD, either an oral SERD or fulvestrant, but we didn't know that back then. When this trial was designed, it was designed in 2012. People didn't understand that. And obviously what happened in this particular study was that you can see there was no benefit. It was, basically no overall survival benefit in this trial. And everybody's scratching their heads because why would that be? Why would there be an overall survival benefit when the PFS, the hazard ratios are basically the same? And so people were kind of a little confused about that. But one thing that was kind of clear, that when you took the patients in Paloma 2 who were very similar to those in Monarch 3 and I think Mona Lisa 2, you took them to the other two, and you took people, and all those patients had a disease-free interval of greater than 12 months since their last aromatase inhibitor. When you looked at that section of the trial, basically you had an overall survival that was the same as the other two, about 64, 65 months. So, things pretty much, could have been explained in this study by differences in the patient population. But again, statistically, you can't really talk about that, right? You're kind of choosing post hoc, right? And the statisticians don't like that. And so, so that's kind of the deal. However, when you go and actually look at some other data, this is randomized data now, and this actually is important for a number of reasons in this field. When you look at Parsifal, there's Parsifal, which initially was a trial of fulvestrant palbociclib or letrozole palbociclib up front. It was a randomized study to see if fulvestrant palbo was better than letrozole palbo. It was a randomized trial, and it was followed. 389 patients, not a huge study, but it was followed for a long time. So initially, there was no PFS advantage to the difference. And that's important when we're talking about oral SERDs in the first line, which is a whole other conversation. But nonetheless, this is a randomized trial, very well controlled, and most importantly, the patients all were very similar to those in the Mona Lisa and Monarch first-line trials. And when you look at this trial and you look at overall survival, what they found is that there was no difference, number one, between fulvestrant and letrozole when you add it to palbociclib. But most importantly, I think when you look even more carefully and you combine the overall survival is 65 months. So in a patient population, in a randomized clinical trial controlled setting, now it's not against aromatase inhibitor alone, but it's in a controlled setting with identical patient population as the other two CDK4/6 inhibitors, it's basically the same overall survival. It's about 65 months. And I think that putting that together, I think, most of the NCCN, ESMO, ABC5, now ABC6, it's almost 7 now, ASCO, we all recognize that the CDK4/6 inhibitors are generally the same. I mean, there may be a little bit of a preference to ribociclib from the NCCN right now, but on the other hand, I think internationally, everybody recognized that CDK4/6 inhibitors and endocrine therapy are the standard of care for first line. Now, we can talk, there's a whole other thing, about whether we should be using it first line at all. There's the SONIA data that suggests you can use an AI and then a CDK4/6 inhibitor, and we can talk about that later. But nonetheless, I think the guidelines really are, at this point, really suggesting that at least from an efficacy benefit, there's not much of a difference between the three. Where there are differences, though, are toxicity. And I think that This is the comparative toxicity, and I'm going to show you a little bit more detailed data in a very busy slides. And I'm just going to briefly show it, but it's an interesting slide. I'll show this one first. And really, the first thing we notice is that with palbociclib, there's a bit more neutropenia, I think, than the other two. A bit more grade 3 and a grade 4 neutropenia, because it really does bind CDK6, almost the same as CDK4. CDK6 is what is involved with neutrophil maturation. CDK4 is really the active protein in the tumors. And what you notice is that there's more neutropenia with palbo and with ribo than with abema. Abema only has a grade 4 neutropenia rate of about 1.5% versus about 10 or 12% with the other two. The other thing that's important is that there's more diarrhea with abema. You can see here is a 9.5% grade 3 diarrhea rate. And again, people may feel it's the CDK9 that may be doing this. But really, there is even a little bit more diarrhea with ribo than with palbo. And the other thing that's important is that specifically there is a little bit more LFT abnormalities with ribo than the other two. There's about a 10% grade 3 and 4 transaminitis, which resolves in the vast majority of patients, but still about a third of patients have long-term LFT elevations that you have to hold their therapy while you're trying to kind of let that resolve on its own. But I think Guy Jerusalem and one of his junior faculty did a really nice analysis. And again, this is a very busy kind of slide, but I think it's important to point out a few things here. Number one, this first thing is, and we'll just look at the AIs, because that's what we're looking at the comparison. When you compare abema to palbo, there's clearly a lot less neutropenia. You look at these are the ones that are significant, a lot less neutropenia, but interestingly enough, there's more transaminitis with abema versus palbo. There's more diarrhea and GI side effects. You see these brown, these hazard ratios are much higher. There's a bit less alopecia with abema than palbo. More infections, interestingly enough, with abema than palbo. I didn't believe that. I was kind of surprised. And a little bit more discontinuations, kind of a borderline statistical significance. When we look at ribo versus palbo, what we see is there's less neutropenia with ribo. This, again, is a meta-analysis of all the trials that have been done to date. But there's more prolonged QT interval and more transaminitis, a bit more vomiting, a bit less stomatitis, a bit less alopecia, a bit more pneumonitis, believe it or not. There's pneumonitis with these drugs, and a bit more infection. And then when you kind of compare abema to ribo, it's kind of the same thing. The big one is there's a lot less QT interval issues, a lot less transaminitis, a lot less neutropenia, but there is more diarrhea. So again, the bottom line is that these three do have different side effect profiles. So they are different drugs, clearly. And I think that the important thing to remember here, and the way I talk about this now, and this is really the take-home message, is that I think the overall survival, at least in the metastatic setting of all three, is pretty much the same. And I think it's hard for me, and I know I differ from my colleagues in this, and my colleagues are different about this, and that's okay. It's okay to have disagreement. But I think I differ, and I think that, in general, the overall survival of all three, at least from the randomized clinical trials, is pretty much the same. I mean, I think it really is when you look at all the data in totality, especially when you look at Parsifal Long, which really is a randomized clinical trial controlled setting where palbo is being looked at long term. And again, the overall hazard ratio for PFS is about 0.56. The hazard ratio for overall survival is about 0.7-ish. And the overall survival in absolute terms is about 5.5 years. And that was from before. I think it's actually a lot longer now because we're doing a lot better with patient selection. So I think and we have a lot more stuff in the second line and beyond. So I think really right now, I bet you the overall survival of most people, the median is probably about 6 to 7 years, if not longer. And the important thing is that last bullet for people, is that to me, I think the choice of CDK4/6 really should be made on toxicity in the metastatic setting. Actually, it's a different story, but in the metastatic setting, should really be made on toxicity. And we're going to get into that, I think, a little bit later. But that's kind of the most important point here. So, that gets us now to real-world evidence. And why is it important in this field? Well, I'll tell you, it's important when you try to get a drug or a new drug class approved. I'll talk about cancer because that's what I know. You really need as controlled an experiment as you possibly can get. You got to control as many variables as you can. And this is why randomized trials are incredibly important. We have to be very specific about who we select. There's very strict inclusion and exclusion. The treatment is protocol driven, and as we all know, those of us who've participated in trials, and I assume the vast majority of people listening, either as a fellow or even in practice now, have participated in a trial, a clinical trial, they're very, very strict. If someone has a transaminitis that lasts more than a couple of weeks, for example, we wouldn't stop them in clinical practice. We'd probably just wait for it to stop and then redo something else. In a randomized trial, if the side effect lasts longer than a certain amount or is a certain degree, you got to stop. You got to take them off study. The patient doesn't like it, you don't like it, but you got to do it. And so this is really important. The other thing, especially in metastatic breast cancer, where the successes have been quite dramatic, and the median survival of the women is now so long, you have to wait a long time for these trials to get enough events to announce. And that may actually, the problem with it, a randomized trial, is that the standard of care may have changed during that time. And so what you were comparing it to may not necessarily be the right thing to do. I'll give you a perfect example in breast cancer. There's a lot of trials out there, brand new trials that we're going to see at ASCO and probably at ESMO and probably San Antonio in the next 6 to 9 months, where everybody's compared to fulvestrant as a control arm, as second-line therapy. And the problem is that that's not a standard of care anymore. We use fulvestrant with something else. And so it's really hard to kind of wrap your head around that. And that's a problem with randomized trials, unfortunately. So how can we kind of add to it? It's not going to replace randomized trials. This is really important to understand. Real-world data is not going to replace it. It simply will add to it. And so real-world evidence is how you treat patients in the real world. It's like the patients are diverse, they're unselected, they're typical people. They may have different performance status. They may have borderline, LFT abnormalities, CBC abnormalities, platelet thrombocytopenia, whatever, on the borderline performance status issues. Elderly, for example, we're going to talk about that in a minute, that are different than you see in practice. And the treatment is at your discretion as a physician. And usually the outcome measures, docs can decide. It's very difficult from a real-world evidence database to find actual radiological progression. We're trying to figure it out, but it's hard to do. And so really what you've got to do is that you just base it on whether the doc said the patient's progressed or not. And so these are all kind of the issues in real-world data. And I think it's good that way, but the problem is, because of that, there's a lot of bias, right? There's confounding by indication. We tend to take the people who are poor performance status and give them the less aggressive therapy, for example, as we're going to see in a minute. Or databases have missing data. You clearly specify in a randomized trial what you're collecting up front, and you got to collect it or people get really mad and you get docked for it, when you're running a clinical trial. Whereas in a real-world database, there's a lot of missing data. There's also who you decide to do. What we try to do when patients, especially in these kind of prospective observational studies, what we try to do is tell people, look, try to enroll your next 50 patients in a row. But people don't do that. Sometimes people don't want to come in, they don't want to fill out the forms. So, there's that bias there. You're selecting people out, and you're selectively reporting who does well and who doesn't. And so you have a lot of bias. And so for that, what we try to do is almost a kind of a pseudo trial design. We use these techniques, I'm not going to get into much detail about them, called inverse probability treatment weighting and propensity score matching. You hear a lot about this sort of stuff. But the bottom line is when you're looking in a real-world database, either prospective or retrospective, what you're trying to do is make the groups as close as possible. So it's almost a pseudo trial, but it's not. You're not really randomizing them, and statisticians are quite right about that. It's not really randomizing them, but you're trying to make the groups that you're looking at as close to as each other as you can. And so let's talk a little bit about kind of the CDK4/6 space and some of the stuff that's been done. Clearly, because palbociclib has been around longer than the other two, most of the data we have right now is with palbociclib. And I'll focus on that only, not necessarily because it's the only one, it's because just we have more data on that right now. Ribociclib and abemaciclib are coming up with data as well, and we'll see a little bit of that at the end. But the thing is that the only reason I'm focusing on it is because we just have more data. And so the first one we did was this P-Reality X, and what this was actually looking at the Flatiron database, which is a database of about 3 million records in the US. And many of you may have participated with Flatiron, and the deal they will cut with you is that, look, we'll give you a database at a discount, but we get to collect your data in a de-identified fashion. That was kind of the deal that was struck. And so in the Flatiron database, we took two groups starting at about February 2015 when the drug was approved up through March 2020, about a 5-year period. There were about 3,000 patients, about 1,300 had palbo and an AI, and about 1,500 had an AI alone. And what we're trying to do is figure out the overall survival of these patients, how well they did. That was pretty much the bottom line. And, this just shows you what happens when you propensity score match the patients and you do, or inverse propensity treatment weighting. You go here from, the patients clearly more had an AI. When you match them, they now were equal. When you look at the age of the patients that were on AI, you see 40% went down to 33%. Performance status. So what you're really trying to do is match the patients, because as you can tell, patients who are older, with visceral, non-visceral disease, poor performance status, were getting the AI and not the palbociclib. And so you're trying to kind of match them. So that's kind of just shows you in real world timing how this works. And the bottom line to this is that there was a survival advantage. The absolute numbers were not as great because, again, these were older patients. They died of other causes. This is not really breast cancer specific survival. This is overall survival, so it's not a surprise. These numbers are lower in both the control and the treatment arm. But you can see here there was a benefit that was statistically significant with a hazard ratio about 0.7, about 0.7 when you average it across all these various, both the unadjusted, the inverse probability treatment weighted, and the propensity score match. And so that's number one. One of the things you also do when you do this is try to do sensitivity analyses. So we wanted to see whether the progression-free survival in the real world was similar to that in the clinical trials, and the hazard ratios were a little bit less, probably reflecting the fact that these are sicker patients, and we as docs probably tend to take them off the drug earlier. The hazard ratios were a little bit less, or like 0.6, 0.7, as opposed to 0.55 in the other trials. But the bottom line is that there clearly was benefit in the real world to the CDK4/6 inhibitor over the endocrine therapy only. Other ones that we kind of looked at, time to subsequent chemotherapy, which was studied actually in the randomized trials, very similar. You're delaying the onset of chemotherapy of these women probably to about 30 months. That's number one. And number two, the big one is PFS2. Because we know from the SONIA trial, which is a randomized trial of giving the AI first or the AI and CDK first, that PFS2 is the same. But in the real world, and this has actually been replicated now, not only with Palbo, the PFS2 is actually better when you do the Palbo early. So this is really going to be an interesting conundrum in the next couple of years, where we try to kind of figure out how to explain SONIA and how to kind of make it kind of fit with the real world data elements that we've seen so far. So again, what this allows you to do, the real world data, is look how these things perform in the real world and compare them to kind of the clinical trials. So we did a bunch of sub-analyses of the data of the P-reality. The first one was took about 300 patients who had Palbo and letrozole and about 221 who had letrozole alone. We propensity score matched them. They had lung or liver mets. I'm not going to show you too much, just showing you that basically that we balanced them. That's all this shows. You can probably look at this in more detail later, but they were balanced, the two arms. And obviously, very consistent. If you had lung, visceral metastatic disease, you still had a benefit. The hazard ratio still, was about 0.6, but the absolute numbers were lower because people with predominantly visceral disease do worse than those who have predominantly bone and soft tissue disease. It's not a surprise, but with the lung mets, you saw a difference. With the liver mets, you saw a difference. So that was good. Other things that we did, again, looking at patients with cardiovascular disease. And so we actually did a sub-analysis just published in the Oncologist about 6 months ago of the P-reality index data of the patients who had cardiac issues. And as you can see here, most of them had at least 3 cardiac comorbidities, actually, in this analysis. There's the cardiac comorbidities. It looks like, a quarter had a prior MI. 40% had congestive heart failure. About 25% had peripheral vascular disease. Another 35 or 36% had strokes. So these were actually not just patients who had hypertension, or coronary artery disease. They actually had, complications of their heart issues. And as you can see here, there still was a benefit to the palbociclib in all of these patients. So suggesting that, again, if you're kind of a little reluctant to use ribo because of the EKG issues, Palbo is a reasonable option. That's kind of why we did this trial. So that was that. So the other thing that's kind of important is another case. So in that person, going back to her, I'm okay with Palbo and Abema, and that woman with bundle branch block, I probably wouldn't give her ribo. So based on all the data we've shown. So now we have a woman who's 77. She has a history of stage 1 breast cancer in 2013 and had the typical therapy for a 2-centimeter ERPR positive HER2 1+ tumor, was given 5 years of adjuvant AI. And it's now, 8 years later, she has right hip pain. You do a CT of the chest, abdomen, pelvis. She's got a lytic lesion and a right crest. with bone scan uptake. You biopsy it, and she's got metastatic breast cancer. You're pure positive. So what do we give her? And so now we kind of look at older patients. And older patients really weren't represented that well in the randomized trials. So there's a bunch of trials that were done. This is Polaris. It's a real-world analysis, a prospective real-world analysis. So that was done over 2 years. You had patients who just came in who were on CDK4/6, and then you just prospectively studied them over a period of 2 years. Those 2 years of follow-up here. And we can glean some insights from this. And I think the important thing to note here is that 70% of the patients were over 70 years old in this analysis. That's really important when we talk about this. And, this is really kind of data just showing that the global quality of life in these women were not affected. And, there were some geriatric assessments that were specific to the elderly, like the ADLs and the G8. And what you can see here is that there's really no difference in the quality of life that occurred with these patients. There's no detriment in quality of life in older people, who get CDK4/6 inhibitors. And I think that's important. So from a toxicity standpoint, even though there's probably a little bit more neutropenia, at least with palbociclib in this case, and maybe a little more diarrhea when we look at abema in these women, the overall quality of life was not affected. So that's always the question we ask. Are we going to make a older woman miserable with this? And at least from the real world data, the answer is no. And just to show you that these women actually had a lot of comorbidities. I mean, these were not like they're typical women. That come in, vascular problems, metabolic issues, Charleston Comorbidity Index of at least 1 to 2. At least 60% of the patients. So these were not typical patients, and they were typical elderly patients. So we went a little further and looked at actually the SEER database, and SEER is run by Medicare. So this is a database of all the patients on Medicare. So it's very nice data that we can probe. And we looked at the SEER database and we did this experiment. We looked at the people who got palbo and AI alone. And we did, again, propensity score matching. It was a subset of about a little under 800 patients. And we propensity score matched them with SEER, a group that had palbo and AI in the first line and a group that had AI in the first line. Again, we only use palbo because in this case, there's more data. It's been around longer. I mean, obviously, we're repeating a lot of this stuff with ribo and abema, but that's why we use palbo. And just to show you here, again, not surprisingly, there was a benefit whether you do propensity score matching, inverse probability treatment weighting, or unadjusted. They basically are all the same. You have a benefit here, an overall survival benefit. Now, again, and the hazard ratio is a little bit less than you would have expected when you adjust, because again, these are sicker patients. Okay, number one. And number two, they're older. In this particular analysis, if I remember correctly, I think about 40% of the people were over 70. I think about 20% were over 80. And the issue here is these people are going to die of other things. This is not breast cancer specific survival, so they could die of something else. So that's why the numbers are a little bit less. So going a little bit further here, and the last thing I want to talk about, and this is really, I think, where this has gone and what we've all really wanted to do. And these are just 2 trials of many that have been presented and are ongoing. I'm just showing you because I was involved in them, but there are other ones that are involved. But these are many trials comparing all 3. And we're very interested in this, obviously, for a variety of reasons. But P-Verify basically looked at the Flatiron database. And basically, it started with, just looking at this whole consort diagram. You really had to go through this whole database of 700,000 patients, to get down to 10,000 who had first-line treatment with an aromatase inhibitor and one of the 3 CDK4/6 inhibitors, and there's some exclusions. But at the end of the day, you had a huge amount on ribo, obviously, because ribo's been around longer. And then you have about 1,200 with ribo and about 1,000 with abema. But with palbo, you had almost 4 times as many, just because it's been around longer. We have more data on it. And the cool thing about this is that it used to take us 9 months, 12 months to manually extract the data. Now you have AI. And so what you do to the AI, you give it a bunch of parameters, you send it into the database, it gives you data, and you kind of iterate it back and forth. You have, obviously, content experts look at it and say, well, this is reasonable, this isn't. Let's go back and forth and get the data. And you can get this data now in 2 weeks, 2 weeks to 4 weeks. I'm not going to overpromise for Flatiron, but the bottom line is that you get it, and I think you get the data back really quickly, allowing us to get this data a lot more quickly. And looking at P-Verify, clearly there's a lot of censoring because there's a lot more longer-term data from palbociclib than abema and ribo, but at least in P-Verify, a trial of over 9,000 patients, there's no difference in overall survival, whether you adjust it by IPTW or you had unadjusted. So at least in the real-world data, in the real world, it appears again, with all the possible biases and short follow-up for the other two, there doesn't seem to be any difference in overall survival between the three. Now, interestingly enough, I participated in that in P-Verify. I think I'm the senior author of it, but I also did a trial. And the reason this was done is actually the FDA wanted to know for Serena-6, which we're going to see at ASCO this year, whether it could be applied to all three CDK4/6 inhibitors. And they wanted to know whether the survival of all three was the same. And so we kind of did the same thing. We looked at Flatiron. In this case, we took 4,500 patients with Flatiron who had all three. Again, a lot smaller with ribo and endocrine therapy and abema versus palbo. But we also looked at Tempest. Tempest had a database as well of this, and it was about 600 patients in the Tempest database. We had two independent databases together and combined the data. And what we see is the same exact thing. There's absolutely, when you look at the hazard ratio, there's no difference between the three in terms of overall survival. Again, with a caveat, looking obviously at the number of people at risk after 30 months, there's a lot more, with palbo than with ribo and abema. And obviously, we got to follow this for a little bit longer. But the bottom line is that there doesn't seem to be any difference between the three, at least in the real world evidence that we see. It's just, again, the overall survival, when we kind of just look at the people who had it in the first line, there's really no difference. That was a combination of first and second line, that other database. So just to kind of summarize all this, I think that, again, real world data in general expands the body of evidence. It won't replace a randomized clinical trial. I don't think it will. We need those to approve drugs and probably get new indications. But I think, if you're ever having a question about whether a drug is useful, I think real world data really does fill in the gaps. I think that's really important here. And it's complementary. It's not going to replace clinical trials. I think what's really going to be complementary is in how do we sequence all these drugs. We have such a plethora of things that are available to us now. How do we sequence it? And I think that, again, at least applicable to CDK4s, and this is kind of the point that, my colleagues may disagree with me on this one, and that's okay, is that at least the real-world evidence shows no difference in OS between the three. And I think that this is going to be important when palbociclib becomes generic in 2027. What are we going to do? Clearly, this is the metastatic setting. We can't go back to the adjuvant setting. But there are clear differences between the three, in the adjuvant setting. But at least to the degree that clinical data shows us, there does not appear to be a ton of difference between all three in the metastatic setting right now. So with that, I'll kind of stop. And again, thanks for letting me give this talk. Thanks.